Thank you for your attendance at this review of an important and clinically challenging topic in gastroenterology. We hope that the information provided will be useful in your clinical practice. As defined by the American College of Gastroenterology's 2004 practice guideline, goals of therapy in ulcerative colitis include induction of remission, maintenance of remission of symptoms and mucosal inflammation, and an improved quality of life. Our case study patient is a 28-year-old female accountant with moderately to severely active left-sided ulcerative colitis, which was diagnosed 2 years ago. Over the past 2 years, she has been treated with mesalamine 4.8 grams per day, together with mesalamine enema 4 grams per day. Enema therapy was stopped after 4 weeks, and oral mesalamine 4.8 grams per day was continued as maintenance therapy. She has experienced recurrent flares with severe cramping, abdominal pain, and bloody diarrhea. She has missed work frequently. Recurrence was treated with prednisone 40 milligrams per day for 2 weeks and subsequently tapered. Currently, she's unable to reduce the prednisone dose below 10 milligrams per day without a recurrence of symptoms, including increased stool frequency, pain, urgency, tenesmus, and recurrence of blood in the stool. She has never been treated with a biologic agent or an immunomodulator. Initial treatment of ulcerative colitis is guided by clinical severity of disease as well as anatomic extent. Severity is often assessed in terms of mild, moderate, severe, and fulminant disease. Anatomic extent may be limited to distal UC, including proctitis limited to the rectum, or left-sided disease extending to the splenic flexure. Extensive disease extends beyond the splenic flexure, potentially involving the entire colon, as with pancolitis. 5-aminosalicylates remain the first-line therapy for the majority of patients with mild to moderate ulcerative colitis. However, a number of considerations arise when using 5-ASA therapy in patients with ulcerative colitis. These include questions of the dosage for induction and maintenance of remission and the ideal mode of administration. An evolution towards single daily doses has occurred in an effort to improve compliance. It has been clearly demonstrated that multi-dose regimens and the requirement for multiple pills can affect compliance. In one study, compliance with oral 5-ASA regimens was only 40%, and non-adherence has been associated with a 5-fold increase in risk of relapse. Topical therapy with suppositories is suitable for proctitis, and topical enema therapy is required for left-sided colonic disease that extends proximally to the splenic flexure. In patients with limited disease such as proctitis, proctosigmoiditis, or left-sided colitis, topical therapy in the form of suppositories or enema can be discussed as a treatment option. Despite evidence that it is very effective, however, many patients do not like topical therapy, and they may choose oral 5-ASAs over topical agents, even in limited disease. Oral medication is required for patients with more extensive disease or those who are averse to topical therapy. Oral 5-ASA medications are available in controlled release and delayed release formulations, including the newer delayed and sustained release MMX matrix formulation, which is the first approved once-daily 5-ASA treatment option for patients with ulcerative colitis. It remains unknown whether the release properties of these agents confer any additional therapeutic benefit. Studies have demonstrated that a combination of oral and topical therapy may provide maximum benefit in some patients, as demonstrated by Safdie and colleagues for distal disease and Marteau and colleagues for extensive disease. A potential independent benefit of 5-ASA therapy is the prevention of dysplasia or colorectal cancer. Several studies have demonstrated a benefit of 5-ASAs in this setting. This case, however, presents the clinical issue of how to approach the biologic and immunomodulator-naive ulcerative colitis patient who is failing conventional therapy, including both 5-aminosalicylates and corticosteroids. By definition, this is a steroid-dependent patient, and one option that might be considered in such a patient would be to continue corticosteroids. According to 2006 guidelines from the American Gastroenterological Association, however, individual patients with either CD or UC who experience a severe flare of disease requiring corticosteroid treatment or require retreatment within the year with another course of corticosteroids should be considered for initiation of therapy with azathioprine 2 to 3 milligrams per kilogram per day or 6-MP 1 to 1.5 milligrams per kilogram per day in an effort to avoid future corticosteroid use. The AGA specifies that infliximab is another option in this situation, as is combination infliximab antimetabolite therapy. Oral corticosteroids in ulcerative colitis are generally reserved for patients who are refractory to oral aminosalicylates or for those whose symptoms are severe enough to demand rapid improvement. In the population-based one-year natural history study from Olmsted County, 34% of patients required corticosteroid therapy. 54% of those patients achieved complete remission within 1 month, but 46% had only partial remission or failed to respond. Only 48% of patients had a prolonged response to corticosteroids, 22% were steroid dependent, and 29% had required surgery at 1 year. The need for corticosteroids in ulcerative colitis is a marker for more aggressive disease with a poorer prognosis. As shown here, data from the Olmsted County cohort, the need for surgery may begin to arise relatively early in the course of patients who require corticosteroid treatment, with almost 30% requiring colectomy by the end of 1 year and a substantial proportion requiring surgery even earlier. Very similar results were reported in a 2006 study by Ho and colleagues at the University of Edinburgh. This study is only the second study worldwide describing the natural history of corticosteroid therapy in ulcerative colitis. Data were based on a 5-year hospital-based inception cohort of IBD patients diagnosed at Western General Hospital, Edinburgh, Scotland. 63% of patients diagnosed with ulcerative colitis required corticosteroids. At 30 days, 51% of those patients achieved complete remission, 31% were in partial remission, and 18% exhibited no response. At 1 year, 55% were in prolonged response, but 17% were steroid dependent and 21% required surgery.